Welcome everybody to this week's Miami Clinical Brain Tumor Symposium. Today is Wednesday, November 11th, and we are joined today by Dr. Carolina Benjamin, Assistant Professor of Neurosurgery at the Department of University of Miami. Dr. Ivan, who is the director of this symposium. He is also the co-director of research at the Brain Tumor Initiative, as well as a neuro-oncology and skull-based specialist. Also joined by Dr. Jacques Marcos, who's the professor and co-chairman of cerebrovascular and skull-base here at the University of Miami, and Dr. Komotar, who is our program director and as well as the director of the Brain Tumor Initiative. We'd like to give thanks to our admins who help make this symposium possible every week. Especially Iggy, who has helped us along the way, as well as Ingrid, Roberto, Christina, and Dermari. Here is our social media for you guys to follow us. Please join us. You can join us on YouTube. All these videos are also recorded, and they will be available for you to join, to listen in afterwards. So you can just follow it on our website, and you can see us either on Instagram or Twitter. We are also hosting a joint cerebrovascular and skull-based symposium every Thursday at 5 p.m. Led by Dr. Morcos and our team here. Don't miss tomorrow's lecture with Dr. Kongadal and Dr. Greg Thompson, and as well as a great group of panelists. And then we just started as well a pediatric symposium every Monday on Mondays, and next week will be Dr. Sweetain. So please join us next Monday as well. And then I believe December will be the next lecture after that due to the Thanksgiving holiday. Next week, just a little preview, is Dr. Gabriel Zada from USC giving his talk on minimally invasive and port-braced cranial tumor neurosurgery in 2020. So just a little preview for what's coming. Some housekeeping: participants, please ask your questions in the Q&A button on the bottom. We're not offering CME credit, but you will get email confirmation documenting participation. So please, if you enjoy this, follow us or share our videos in the upcoming symposium on Instagram, Twitter, or YouTube, whatever you like, with your colleagues. Now to the good stuff. This week we have a great group of panelists. We have Dr. Fred Talishi, who's the chairman of ENT here and neurotology at University of Miami, also a professor and the James R. Chandler chair. Dr. Clifford Brown, our current or our past neurotology skull-based fellow here, was a resident at Duke, and he also has been a great, tremendous teacher to all the residents and fellow here at University of Miami. Dr. Chris Graffio, a fellow NYU alum, nice to see you. He is now at the Mayo Clinic in Minnesota, and he is working very closely with Dr. Link, has gotten a great group of experience down there at the Mayo. And Dr. Michael Ivan, one of our own, will also be presenting a case today. Now, for the meat of the talk, it is a great pleasure and quite an honor to welcome Dr. John Golfinos. Didn't think I'd be actually introducing you this quickly, just a year after finishing my residency and fellowship with you. So it really is quite an honor. Dr. John Golfinos is the Joseph Ransohoff Professor and Chairman at NYU, as well as member of the Neuroscience Institute at the NYU School of Medicine. He is a New Yorker at heart. He's from the concrete jungle, went to school at Princeton, and then after that did Columbia for medical school, and then went on to the BNI. Pretty sure the BNI was the first time that he actually got a driver's license, showing you he is a true New Yorker. After that, in 1995, went back to NYU, back to New York, joined the group at NYU where he's been since, and has done tremendous things. He's co-founded the NF2. The NF2 program there at NYU, as well as the Gamma Knife Society, and became chairman there in 2009. And Dr. John Golfinos is the current president of the North American Skull-Based Society. And personally, for me, a tremendous mentor, probably has been one of the most influential people in my career thus far, and has a true gift for really creating teams and just a gathering phenomenal group of people. And you can see here at the bottom, this is the group at NYU, the NYU Giants, if you will. He's pretty much knowledgeable in just about everything. So today, Dr. Golfinos, we're very excited to hear you give us a talk about the ABCs of ABIs. And if you could, please share your screen with us. Welcome.
Wow, I don't even know what to say after that. First of all, I want to know, how come you have more pictures than I do? I can have some of those pictures.
I'll send them to you.
Yeah. Let's see. Let's go full screen here. So it really is a great pleasure to present. It's a topic that I happen to love. The ABCs of ABIs, auditory brainstem implants. The way to think about it is this is really the first and most successful cyberonic implant in humans by far. So it's by far the most successful sensory replacement of any. So really, it's a great honor to be here. Thank you so much for inviting me. And it's great to see Carolina down there working in Miami and having a great time. Also great to see Chris Grafeo, who I got to mentor as he passed through as an NYU medical student. And Mike, good to see you again. Good to see everybody. That's me. The only thing to note here is I am jointly appointed in ENT, and usually it doesn't mean anything. But for our team, it's meant a lot. So that a lot of our ENT colleagues are cross-credentialed in neurosurgery. And that kind of makes it official. This is our little spot on the East River before the new hospital was built. This is as they were putting it together. You can see that there. I have disclosures. I have stock ownership in Bure, which is, I think it's worth pennies now. Stock ownership in surgical theater. I will discuss an off-label use of an FDA-approved device, which is the auditory brainstem implant used in children. It is FDA approved, but we'll talk about an off-label use. And at some point, I will say gamma knife instead of stereotactic radiosurgery. I may also say Xerox, Kleenex, etc. I'm a consultant for Major League Baseball Players Association, which is not relevant, but it's still really cool, so I always put it in there. Please feel free to visit my Sunshine Act website. The other disclosure, as Dr. Benjamin mentioned, is that I am a New Yorker. Here's a couple of ways you might know that I'm a New Yorker. This is how people talk in New York. These are maps that the New York Times put together of dialects, local dialects. So in yellow, these are the places that, what do you call it when there's rain falling outside, but the sun is still shining? In these yellow places, we call it a sun shower. Now you'll note through all of this, there's a lot of similarity between New York and Florida. What do you call a group of people? This is you guys in most of the country. In the South, of course, it's y'all. The plural of y'all is all y'all, in case you didn't know that. But in New York, we usually say you guys, and that's the same thing in Florida. And there's this little tiny area called Pittsburgh where they actually say yins. And sometime you can ask Carl Hallman about that because he grew up saying yins. Yeah, what are yins doing next week? We call carbonated beverages soda, like they do on the West Coast and like they do in Miami. So you'll notice all the similarities between Miami and New York. I guess there's still parts of the South where they call it Coca-Cola. Who knew? Otherwise, so Carolina mentioned, I got my driver's license at the age of 27 when I arrived in Phoenix, Arizona. 7 days before starting my residency, I learned how to drive. I figure learn how to drive, learn how to do neurosurgery. It all fit together for me. And that's all because I was able to take the bus to high school. I took a train onto the college campus. And I took the subway to medical school. So I had no need of a license until I got to Phoenix, of course. And how do you know I'm a New Yorker? Last time I did one of these Miami lectures, my co-lecturer said it was the fastest he had ever heard anyone speak English. And English was, of course, not his first language. So I will at times try to slow down if possible. Competition. Miami is famous for the softball tournament. Now that Rick Komatar is down there, we take our competition very seriously. Unfortunately, because we're from New York, we're not really good at things like sports, because we live on concrete. This was something that was put out by the Johns Hopkins Department of Neurosurgery. I don't know if you all received this, a giant, thick book called The Special Field of History of Neurosurgery at Johns Hopkins. And so we would never be outdone. So first of all, we would like to remind our Hopkins colleagues that Halstead got his start at Bellevue. So it all started at Bellevue and NYU. And so this is our book. We kind of, I put it together myself. You can see our history of neurosurgery at NYU. So we are just as competitive as everyone else. I have to mention my partner in crime, Tom Rowland. And this is all about teamwork. We've been working together for 25 years now, which is kind of like a marriage. That means we fight over money. We fight over his never being there for me and vice versa, because he's off traveling to meetings and so am I. I always tell him he's a slob because I have to come in there and do all the hemostasis after he's been mucking around in the tumor. And then we always fight over the chores, like who's going to round. So it's truly a 25-year, more like a marriage than anything else. Today we'll talk about ABIs for NF2, and then we'll also talk about ABIs for cochlear nerve aplasia, which I currently am doing more of the latter than the former, because you'll find in your NF2 population that you end up doing a whole run of them early on, and then you end up basically having implanted most of the patients who are candidates early on, and then sporadically as new patients arise and come in. This is what happened to us after the Superstorm Sandy. This was our Gamma Knife unit. You can see the water went all the way up to the roof. Things got better. So this is making lemons out of lemonade. Some of the money that came in was allowed us to go forward on this new hospital. This is the Kimmel Pavilion. It's a tremendous facility. This is where we do all of our surgeries now. That is the dog that they put outside for the kids hospital. You can see he was balancing a New York taxi on his nose. And so if you're trying to find the Children's Hospital in New York, just say, go to the giant dog with the taxi on its nose. So just to review, it really is an implant. It really is, as we mentioned, a bionic implant. So it takes the place of what would be the normal hearing system. So cochlear implants are the step before auditory brainstem implant. You can see in this diagram how it works. A sound processor worn over the ear captures sound, turns it, and then digitizes it. That digital signal gets sent, is actually that signal or that sound is processed in the processor here through a magnet connection. And then that gets sent down a wire into a cochlear implant, a wire that's placed into the cochlea with electrodes on it. And that stimulates the cochlea in the same tonotopic fashion that the normal cochlea would be stimulated. And then that gets read out or passed on to the cochlear nerve in a very natural fashion, because you're stimulating the cochlea the way nature intended, except you're using electrical signals instead of acoustic signals, which normally would come from the tympanic membrane. So that works really well, but what do you do if there's no cable here? What if there's nothing connecting the cochlea to the brainstem? This won't work. So that's where auditory brainstem implants come in. They take the place of the cochlear nerve when people are born without one. And that's what this looks like here. Same thing, so kind of the same sound collector worn over, or microphone really worn over the ear, that then passes the sound into the processor. This is a ground wire, but the processor sends a signal down the wire to a paddle, the blue thing, and that paddle then goes into the brainstem where it stimulates either the dorsal or ventral cochlear nucleus, or both, or neither. It's not really clear. We think it's the dorsal cochlear nucleus. This is NF2. You've all seen this. You know what it means. Bilateral tumors, and inevitably in this disease, the better hearing will be on the side with the larger tumor. And that happens because these don't grow like conventional vestibular schwannomas. They tend to infiltrate the nerves more, so you can have working nerve fibers going through this tumor, and you can still have hearing even in a tumor this size, which obviously is problematic. And that's why this led to the use of Avastin and medical treatments to medically control these tumors. In fact, we just had our patient day this past Sunday, which we did by a Zoom conference again, and it's astonishing how well-informed these patients are about what's out there and what's the next best thing. They know about every clinical trial as soon as it hits clinicaltrial.gov, basically. So the auditory brainstem implant was FDA approved in the NF2 population. Originally, it was for 12 years of age and older, and it was approved, or it is approved, for implantation at the first or second side tumor surgery. It's done most of the time in the US, it's done by a translab approach, and sometimes in Europe, a retrosigmoid approach is used, and the tumor is placed in the lateral recess of the fourth ventricle, basically through the foramen of Luschka, right adjacent to the dorsal and ventral cochlear nuclei. The dorsal, and here's the landmarks: the stump of the eighth nerve, the spinal fluid that comes out the foramen, the lower cranial nerves, and the choroid plexus. This is from Roten's Atlas. And you can see the anatomy that we're confronted with are obviously on the right side. This is the eighth nerve, and this is a normal anatomy. This is lower cranial nerves, ninth nerve, 10 and 11, the choroid plexus. This is how you know you're in the right spot. Usually there's a branch of ICA or pica. Pica can come up this high, but usually an ICA branch giving off labyrinthine artery. And then down here, eighth nerve entering into the superior portion of the foramen. There is inevitably a vein here, and this, of course, is seventh nerve in front. There's inevitably a vein right here, right across the entry to the foramen of Luschka. And this retractor, we don't actually use a retractor, but this retractor is lifting the choroid plexus dorsally and backwards, which is what you have to do, but it's also displacing the flocculus. And that's very important. Sometimes you have to free the flocculus from the ninth nerve inferiorly. I just got out of a lower cranial nerve schwannoma in a 10-year-old girl just like 2 hours ago. And it always reminds you that the ninth nerve is not connected to the flocculus. You have to separate them. And that gives you a little bit more leeway to get in here. And then what is this structure? Where's Chris Grafeo? So Chris Grafeo does an unbelievable job running the North American Skull Base Twitter feed and Instagram feed. I mean, a really—
Aw, shucks.
But Chris, I'll be amazed if you can tell me what that thing is right there. And if anybody can do it, I know it's you, so you don't have to feel bad if you can't. This is a really tricky one. It's kind of to the opening of the foramen Alushka right here on the anterior side, the anterior lip. So there's actually a name for this, which I don't know if Roden gave it or not. This is called the rhomboid lip of
Wow.
the
Learning is fun.
This is called the rhomboid lip of the foramen of Alushka. And the reason it's important is sometimes you can have an attachment of the tila choroidea here, where that holds the choroid plexus. So sometimes you have to open this up by cutting the arachnoid around here and freeing the choroid. We've also been in cases in the kids where the choroid was entirely behind arachnoid, so that the foramen wasn't even open on this side. In that case, you have to open the arachnoid, open the tila choroidea, and let it free, and let the choroid go free, and the tinea choroidea. And then this is that vein that always gets in the way. And you'll see when you try to put a paddle in here, you're hoping that the sharp edges of the paddle don't bust this vein, don't get one of these little arteries, and don't hit any big arteries, of course. And it can be done safely. All right, we're back. So we were trying to talk about Chris Grafeo's knowledge of anatomy, which is truly spectacular. Let's go to the show. Okay, so we talked about how to find the implantation site. And there it is. Let's go to a regular show. And it's all about looking for the finding. So what I use now is I find the sharing is paused. Can you see the slides?
Yes.
Yes, yes, we can.
Okay, it just says that sharing is paused, but I guess that's not true. So I use eighth nerve as a great landmark, and when you're dealing with ABIs and NF2, you sort of have to think about it on your way in, or else you will get in trouble. So as you're taking the tumor out, look for the eighth nerve and preserve and mark the stump. Now, this is always interesting to me because some people will say, well, these tumors are so big you can't find the eighth nerve. You can virtually always find the eighth nerve. Maybe not always, because nothing is forever, nothing is 100% in medicine, but you can virtually always find the eighth nerve if you know where to look. And if you're not sure where it is, you'll find that when you get into that point of the operation where you're taking the tumor out and you get into an enormous amount of venous bleeding near the brainstem, and you think you're about to go into the brainstem because you see a lot of mushy white stuff, that mushy white stuff is in fact the eighth nerve, and those veins are the veins around the eighth nerve that bleed all the time. There's a rhomboid lip, so you know what the heck is that? It's actually the anterior lip of the foramen of Alushka, and look for that vein when you're going to put that paddle in there, and try not to make that vein bleed. And then do an electrically evoked ABR, and we use this to judge the depth of the paddle, and I'll go over that a little bit when we talk about the kids. This is an old picture of what the receiver looks like, and these are really old paddles.
Dr. Grafeno said your slides are not advancing now.
Let's see, why does it say it's paused? Let's see. Sharing is paused. Bring your shared window to the front. Hold on a second. Let me stop sharing. Oh, here it is. Resume share. How's that? All right, there we go.
Perfect.
So these are the way the paddle started out. I mean, it actually started out as two little ball electrodes, and these are the ones that were done at the House Institute early on. You can see that they just added more and more electrodes as time went by. And this is the more modern version of the paddle with 24 electrodes. These are the wings that were put to use in ABIs in NF2 cases, because sometimes that foramen can be so blown open by the tumor that the paddle will kind of knock around in there. And the idea was to fold these behind the paddle when you're putting it in. I cut these off most of the time now because I find that they get in the way, and trying to get them folded is kind of tough. The other idea here is that you really want to push these electrodes flat onto the brainstem. So that helps sometimes. And I've kept them on for NF2 cases when there really is a big patulous foramen of Alushka. And then this is the monitoring that you have to do. You can't do this case without good intraoperative monitoring. You obviously have to monitor 7, fifth nerve, sometimes we monitor it, but definitely lower cranial nerves through the NIM tube, the endotracheal tube that has the monitoring electrodes. And that's because when you turn this on, you want to be sure that you're stimulating only the cochlear nucleus and not the facial nerve, for example, which will cause facial twitching or facial spasm, and not the lower cranial nerves, which will cause a choking sensation, and also not systemic problems as well. So you're also looking for SSCPs and MEPs. This is what our incision looks like. We put this sort of S-shaped incision and keep the electrode out of the incision, keep the receiver out of the incision. And this is technically what it's supposed to look like. But the interesting thing about this is when you go through Roten's anatomy, and he did a whole article on the anatomy of this, it turns out that the ventral cochlear nucleus is half in the foramen Luschka and half out. And not only that, the cochlear nerve splits around the ventral cochlear nucleus. So it's kind of it's an interesting arrangement, because most people put the paddle past that rhomboid lip, and that's what I do, and all the way into the foramen. So it's really over the dorsal cochlear nucleus, even though there's a lot of arguments that it really should be at the ventral cochlear nucleus. And maybe that's why sometimes we pull it back and we get better stimulation from the paddle. That's just the stereotactic atlas of looking at the eighth nerve and how it enters the brainstem right there. And this is an intraoperative picture of the flocculus and the choroid plexus, and again, those same arteries there. And you can see the paddle in position, basically coming in. That's the paddle with the wings folded back, so that'll push the paddle flat against the brainstem. And then sometimes I'll put a little piece of fat. Sort of depends on what mood I'm in. Sometimes I just put a little bit of Teflon behind it. Depends on how snug the whole implant feels. If it really feels like it can move around, then I'll put fat in there. And I usually use a little bit of tissue glue as well. These are the NYU early results from probably our first 20 in NF2, where we got 85% of them at auditory stimulation. By the end of it, and there is a learning curve here, so by the end of when we were putting in, everybody got auditory stimulation. But then you go through a phase where you put it in everybody, and then your results get worse again, because you put it into people who haven't heard in a long time. And then the important thing is when they map it, that you get rid of non-auditory side effects, so that, again, they don't have facial spasms or twitches, or they don't have weird sensory symptoms on the side where the AVI is. And so in the original AVI clinical trial for the FDA approval, they asked patients in that trial, would you recommend the AVI to others? And 74% agreed with that statement. And 83% thought that they benefited from their AVI. And then whenever you ask somebody in retrospect, did you make a good decision, you'll get at least an 85% agreement that they made a good decision. And this is borrowed from New York Magazine. This is the undulating curve of shifting expectations, where there's a little bit of pre-buzz and then buzz, rave reviews, then everybody's doing it, then everyone realizes it's overhyped and there's a backlash. And then you get the true backlash to the backlash, and it levels off somewhere. So that's what happened with AVIs. So, originally it was sort of, maybe this will work. Then there were some promising early results. And then the thought was, gosh, everyone's going to hear again. It's going to be amazing. Everyone lined up for their AVI. And then patients started saying, well, I can't really hear on the phone. I can't really hear unless I can't understand what someone's saying unless they're looking right at me. And then the idea was maybe this AVI doesn't work as well as we thought. But then it became clear that it was very useful in NF2 for people who are lip readers, very useful for improving communication, and even people who have open set speech discrimination, meaning that they can understand even without seeing, even without being able to read lips, which is kind of the ultimate. So now, patients ask, when can I get my AVI? They get online early, they read about it, and when they lose their hearing, they understand that there's now a hearing rehab possibility for them. And usually we wait, obviously we wait until there's a tumor that's going to come out, but we like to do it as soon as we can, because there's good data, I think, that and it certainly matches our experience, that the earlier you implant someone after hearing loss, the better they do, probably because so many of those connections are still active. When you ask your neuroscience colleagues, all they can talk about in learning is keeping synapses active all the time. So it seems like it. And then this is the other problem you deal with in NF2. These are meningiomas that are colliding with, probably, these are meningiomas of cavernous sinus that are going to collide with other tumors. And it can be a real challenge to get an AVI in when you have to take out the meningioma, then go down, take out the large schwannomas that are on multiple nerves, and then find a place to slide the AVI in. So we don't do this anymore. We used to have a probe, but now that we've gotten so good at this, which is the electrically evoked brainstem response, we don't use probes anymore. We just open the device. And I heard someone mention it's a $50,000 device. That is true. So as soon as you open it, you really want to use it. And this is what you're looking for. You're looking for this early deflection, which is measured at the scalp. So you're measuring, basically a brainwave at the scalp over areas that are involved in hearing. And that's what it looks like again. And that's what we see in the operating room. So just as an example, there's a 23-year-old with NF2 and a 2-centimeter tumor on the left, 1.8 on the right, dead ear on the left, still some hearing on the right. You can see that 8% discrimination. So we operated the left, did a total tumor removal, kept the facial nerve intact. And here's the electrically evoked brainstem response, and it's a real one. So that's somebody who's going to, as their hearing gets worse on the other side, they'll use the ABI more and more. And that's what we saw, 15 electrodes on the map. And then that was early on after our first, I forgot how many it was by now, but back in 2004, we were one of the first papers out to show ABIs. So that's in NF2. And this is our beautiful lobby again in the new building. These are the shiny floors in our new building. This is our floor, 16th floor. And this is why we claimed the 16th floor. I was actually given a choice. I think it was between the 7th floor and the 16th. And of course, I took the 16th for the neurosurgery service. And these are the views from a patient room. These are actual patient room views out over the East River. But the interesting thing about ABIs for me now, and what we do more frequently than we do in NF2 now, is children who don't have NF2. And so this is broadening the indications of the FDA approval. It's really an off-label indication. So to do that, we did it on a protocol. The great thing about it is it shows you why anatomy is so important, as we were talking about before. MRIs have gotten incredibly detailed. High resolution T2 images will show you the 6th nerve, they'll show you the 7th nerve, facial nerve in front of the 8th nerve emerging from the brainstem. So you can now see all of this, and we can now understand why some children were born without the ability to hear. And then fMRI allows them to, and diffusion coding allows them to find the entire pathway for hearing, and you can see all the parts of that pathway. 8th nerve comes into the brainstem. Remember, there's already an early cross at the trapezoid body. And then it gets processed in the inferior colliculus, gets sent up the lateral lemniscus, and then to the thalamus, to the medial geniculate nucleus. But remember that it crosses early on, and you're seeing that here. So there's a cross in the trapezoid body, which kind of confuses people when they talked about trying to put implants higher up in the midbrain. That's already after processing has occurred down here. And then you can see the entire pathway going up and then eventually out to the planum temporale, to areas that are involved in speech and language recognition and hearing. So that's kind of cool. But the other thing that's happened is it sort of made us aware that some kids are born without a normal cochlea. Here's what it's supposed to look like. On the right side here, you see a cochlea with a well-formed medulus right here. Right, this is the basal turn of the cochlea, well-formed medulus, where the 8th nerve fibers go in there to the cochlea. But this is what happens in some children. They are born without a cochlea. They have cochlear aplasia. So this is the internal auditory canal. You can see a formed fruste of a labyrinth back here. It's trying to form. You can see the entire otic capsule looks malformed, but there's no cochlea sitting here on the anterior side. This is a canal that basically is going to pass the facial nerve as it goes out and around. And so that's kind of this is what it looks like on the MRI scan. There's a facial nerve, but there are no 8th nerve components at all, even though there's a little bit of an attempt to form a vestibular system. And then this is sort of a small cochlea. You can see it here, hypoplastic, no medulus, just this big open gap here. That's another variation. And then again, the IAC is present, and not only is there no cochlea, there really is no significant balance system. You do still have a vertical crest here, Bill's bar, but you can see that you don't have the normal passageways for the nerves here because there's no cochlea here, and there's not really a labyrinth. And that's what that looks like on the MRI. So on the MRI, instead of seeing a big IAC, you see this little hole, and when you get in there in real life, you're looking for the IAC, and all you see is one nerve, which is a facial nerve, going into a hole in the dura. So you really got to know what you're doing. And then the other problem is when somebody has only a facial nerve and they don't have the 8th nerves tethering the brainstem forward, the brainstem in these little kids will start to fall back. So you get this huge distance between the clival recess and the front of the brainstem and where you're trying to go, which is in here into the frame of Luschka. And you got to pay attention to that because this is not going to be easy, especially if you're coming in retrosigmoid and you need to come all the way around this corner and past that electrode, basically blind, so it sits right here on the dorsal brainstem surface. So you got to pay attention to this. These are the hardest ones, kids with multiple malformations where the brainstem is no longer held forward by 8th nerves and instead falls backwards. And this is to show you what it looks like on the MRI. We use this sagittal view. Find it very easy to look at. The anterior side is here, posterior is here. You can see the cerebellum. This is what this graphic shows what the nerves are supposed to look like. Facial nerve above anteriorly, cochlear nerve below anteriorly, and the 2 vestibular nerves posteriorly with the labyrinth. And that's what it looks like on the MRI scan. Here's the two vestibular nerves. This is the facial nerve anteriorly and the cochlear nerve inferiorly. And as you get further out the medulus, here's the cochlear nerve, the vestibular nerves, cochlear nerve, facial nerve. And so again, that's what it's supposed to look like. Cochlear nerve is supposed to be there, but what happens here? Two vestibular nerves, facial nerve, and no cochlear nerve. And that's the cochlear nerve aplasia. So when we went to do this in the kids, we had to do it on protocol. So our inclusion criteria, where if we started 18 months, the FDA would not allow us to do younger. They still will not allow us to do younger than 18 months. And our findings is the younger kids are doing better, which makes sense. We know there's a critical period for language acquisition. So technically, the younger, the better for all of these children, but the FDA has been too scared by that. And then we want to obviously documented profound sensory neural hearing loss. We want to be sure there's no cochlea or a cochlear nerve, or make sure there's hypoplasia of the cochlear nerve. In other words, they can't be candidates for a cochlear implant. And then no medical contraindications. And then this is a critical one, strong family support. The other critical one, no developmental delays. Some parents obviously will want everything possible for their kids, but if the kid has developmental delays, it's unlikely that they'll benefit from placing the auditory brainstem implant because of their other developmental delays. And so that goes with reasonable expectations from the family. And anybody is excluded that has multiple pathologies or other anomalies that make it hard to place the implant. And so that's our regular workup. We get the imaging in these kids. You've got to put the young babies have to get an MRI scan while they're asleep. A lot of time they come to us with the MRI done when they were 1 year old or younger, because they're diagnosed at an early age when they fail the prenatal hearing screening. And then they don't respond to cochlear implant, or they have imaging that shows there's no cochlear nerve. And that's the imaging that we often have to work off, even when they're a year older than that, or 2 years old, or 3 years old sometimes. And then we do behavioral testing. We work with the parents so they have reasonable expectations of what's gonna go on. And then we will always do we try and get an ABR in the kids to make sure it's not there. And then sometimes a promontory stim just to make sure that there's no cochlear nerve. And so on the kids, instead of a translab approach, you're using a retrosigmoid approach, which really is harder because your angle is worse. So you kind of have to pass it blindly towards your own belly button, really, to get it in there. But again, it goes into lateral recess, just like we talked about before. 8th nerve and 9th nerve is an excellent landmark now, because the 8th nerve often will not be there, or it'll be a very thin 8th nerve that has only vestibular components. Trying to slide along the 8th nerve is harder than it sounds, actually, even though it seems like that would be a great place to put it. It's easier to sort of use the 9th nerve to guide you in direction. And then again, finding the foramen with the choroid and using those lower cranial nerves as your guide. And then once we get it in, we do the first thing we do is the electrically evoked brainstem response. And we look to see how many of these electrodes will light up. Basically, how many of these create a signal that can be recorded on the surface of the scalp, just like an EEG, or just like an auditory brainstem response. So we will stimulate first from one end of the paddle to the other, just to make sure the paddle is working, and we'll get a good signal. And then we'll look in groups. So we'll stimulate the distal end, and if that works well, but this end doesn't, then we know the whole thing needs to go in farther. Or if we stimulate and we find that this group works really well and this group doesn't, then we've got to pull the paddle back a little because it's been too far in. And then we look at the superior side and the inferior side to make sure that it's not too high or too low. But often, because you're monitoring the facial nerve, that will tell you also. If the paddle is too high or not in far enough, you'll often get facial nerve stimulation because you're up near the facial nerve nucleus. And if it's too low, you'll start to get changes in blood pressure, or else you'll get stimulation of the 10th nerve. And then you know that the paddle's got to go up higher. And obviously, if you get neither 7 or 10, then you know you're certainly in the right neighborhood. And then it's a question of depth. And that's what the paddle gram looks like during the stimulation afterwards. The electrodes that don't work, the electrodes that work really well, etc. So this is a 20-month-old boy with congenital aplasia of the cochlea, hypoplastic cochlear nerves bilaterally. And if you look at that, it sort of says hypoplastic or aplastic. Sometimes it's hard to tell. But he had congenital and profound sensory neural hearing loss. You can see they couldn't test anything. He failed his newborn hearing screening. And they thought they got some responses. So they thought about doing a cochlear implant, but then they got the radiology and it became clear that there's no cochlea here. So there's no place to put a cochlear implant. And you can see there's no well-formed internal auditory canal. The whole otic capsule is malformed, where there's no balance canals really, and no good. There's just this common cavity here. This is a coronal view. It shows the same thing. And you can see it's not exactly a totally normal brainstem, but there is a arachnoid cyst on this right side. And who are we to say no to a gift? So you can see that this goes right into the foramen Lishka. So we put the implant on this right side using the arachnoid cyst as a way to get in. This just shows that that we have to do an ABI because he did not have a cochlear nerve. That's the graphic for the ABI. And this is the orientation. So this is, remember that the electrodes are going onto the brainstem. So on a right side implant, with those electrodes down against the brainstem, then this will be the superior side of the paddle, and this will be the inferior side of the paddle. You have to sort of flip it in your mind to see that. And again, retrosigmoid approach, we monitor, as we said, especially the facial nerve and the lower cranial nerves. And then it gets activated at a later date. At a second date, the child goes back to the OR, is put to sleep, is put under general anesthesia, so we can test to make sure they don't have blood pressure problems or anything else like that. And this is our small little retrosigmoid craniotomy in the children. That's the sigmoid sinus drilled out, and this is a retrosigmoid bone. And then we just turn the craniotomy, and you're looking at the retrosigmoid dura here. And then this is once the dura is opened, you're looking for an eighth nerve, and there isn't one. These are lower cranial nerves here. Again, looking for an eighth nerve, there isn't one, but instead and this is the membrane. Remember that arachnoid cyst? You're seeing the membrane of the arachnoid cyst and the paddle going into the foramen Lishka there. And that's what it looks like. And that's what it looks like when it comes out, and we anchor it under the bone and make sure that nobody's pulling on this as we close. And then and this is our actual monitoring during the operation. And then the child will come back several weeks later and put under general anesthesia, and they'll test out the paddle again to make sure it's working and make sure that the child doesn't get stimulation of lower cranial nerves, which would stop the heart or something like that. So this child, 3 weeks out, started to demonstrate awareness. Remember, a very young child, which he never had before. The parents noted that he would start to turn towards loud noises, which he had never done. And then by 4 months, he was responding to voices. He was tracking voices, had rapid improvement, and he has open set speech recognition at age 5. This is a 9-year-old girl who came to us after she'd been managed at several other institutions with no cochlea on the left and a hypoplastic cochlea on the right. And you can see they actually implanted the right side cochlea when she was 2 years old. And they thought she had moderate results. It's amazing to me how difficult this can be to judge. But they thought she had some moderate results. The device failed. It was tried to put back in, but because she'd had it since she was 2, for 7 years, she already had some kind of, she already had calcification around it, and it was impossible to re-implant it. So she got sent up here, so it's time for this again. It's time for an auditory brainstem implant on the right, and this is her intraoperative view. These are her lower cranial nerves, and this is what's supposed to be an eighth nerve. This little thing probably includes the nervus intermedius. The facial nerve is this thing in front, but all this cheap white stuff is the eighth nerve, probably with some nervus intermedius fibers right here that are going to go to the 7th nerve. But there's no 8th nerve where it's supposed to be. So that's following the 9th nerve in to place the, and this is what you'll see in the video. It's following that 9th nerve in to place the electrode in there. And you'll see another thing, not a normal ear. She has skin tags. The ear is a little bit low. We had to work through the prior incisions. This is lower cranial nerves, that weird cheap 8th nerve with a 7th nerve in front of it. And this is opening up that foramen, the foramen Lishka. You can see it's always right on the superior edge of the 9th nerve is a great landmark. And if you saw back there, there was that little vein that's always in front at the rhomboid lip. And it's getting, and then dunking the electrode in there and the paddle in there. And it always takes one last little push when you think it can't go further, one last little push to get it. So it's buried up to the hub, basically. These are just some, so you can see some other variations on the left side here. So this is a tentorium up here, and you can see a 5th nerve. You can see the 7th nerve run up along the brainstem to join the 5th nerve to go out. You can see the lower cranial nerves here, and the thing that's missing is the IAC and the 7th and 8th nerve. This is with a paddle in place after implanting that. And again, 5th nerve up here, lower cranials here, and nothing where they're supposed to be, a 8th nerve. And that's placement of that electrode. So this is what a child will look like at 7 months. We're almost done here. At 7 months after the implant, this will give you an idea of the speech and development that they can have in language. So this is a girl who had a cochlear implant on one side. She's taken the cochlear implant off and has the ABI on.
Here we go.
And mom's gonna hide her mouth.
Listen.
So mom's using that paddle to hide her lips so her daughter can't read her lips, because children will become very adept at lip reading, especially around familiar adults. But you can see that she's actually hearing the sound. So is that useful? What does it look like 6 years later? This is what she looks like 6 years later.
Hi, my name is Gwen, and I'm 5 years old. I got CI when I was 2, and I got ABI when I was 6. I go to school with kids who can hear, and I can talk around because of their intellects. I always get best with both, but it could be difficult for me sometimes. I like the ABI, it helps me.
Can you take your cochlear implant off?
Yeah.
So parents want to know, can my child be mainstream schooled? And this child is in a mainstream school, right? And then so mom's gonna hide her face again.
Say a word and you say it back. Birthday.
Birthday.
Pancake. 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 Pancake.
So see the lip reading?
Basketball.
Basketball.
Movie.
Movie.
Hot.
Hot.
Yellow.
Yellow.
Friday.
Friday.
So we call this open set speech recognition. She can understand the words that are being said without seeing her mother's lips moving. And now mom's gonna use sentences and it'll be the same thing.
Question. You tell me the answer. Okay. What grade are you in?
6.
What is your favorite food?
Macaroni and cheese.
Whose birthday was yesterday?
So,
Good, your brother Jevin. What color is your shirt? What color is your shirt? What color is your shirt?
black.
Good job. Thank you.
So those are really good results for a child. It's kind of amazing. So she grows up basically in the hearing world. But you can see the limits of what they can do with the programming currently today. But that's where all the research is, and trying to get more electrodes in there, trying to get the right programming schemes so that it's more accessible to the brain, so that the information coming in is accessible to the brain. So things we've learned in doing this is, in children expect the unexpected. Malformations beget malformations. Last week, we were putting one in, the first one that we had to actually abort. And that was because I just couldn't open the retrosigmoid dura. There was just venous lakes everywhere. And it was a young baby, and obviously we didn't want to get into the transverse sinus. I've seen low-lying transverse sinuses. And so you just have to be ready for this kind of thing. The ears can sometimes be low-lying, and the transverse sinus will follow that. So you've got to really be aware of that stuff. In adults, NF2, the disease, will ultimately determine the success of the implant. And then the key is that early implantation or short duration of deafness is still the best prognosticator of open set speech recognition. So both in the children getting it in early when they're young, and in the adults getting it in soon after they lose hearing, or immediately after they lose hearing, or even better while they still have some tiny residual hearing left. So I always have to close, whenever you see a basic science talk, they show their lab and the people who do all the work, and their mentors, and these were my mentors, Robert Spetzler and Pat Kelly, who are two of the best surgeons I've ever seen, intraaxially and extraaxially. Every department should have a motto. Ours is ancient Greek, because I'm a Greek. Ayin Aristevin, which is from Homer's Iliad, book 6, ever to excel, to do better than others, and to bring glory to your forebears, who were indeed very great. So thank you very much for the opportunity. I'm happy to answer questions or look at cases. Thank you.
That was fantastic. Thank you so much. Excellent overview. I think Dr. Talishi, are you with us?
Hey, Carolina, can I ask a quick question to John? John, sorry, I joined a little late. You see where I am having fun on Miami Beach here. Thanks for doing this. listen, with your pediatric experience, should you, I mean, does the distance where you place the electrode as a child grows, is that even a consideration? Like they don't outgrow, like people, you know, kids outgrow their shunts. Do they outgrow the distance of the electrode?
No, it's a great question. They actually don't, because there's enough redundancy in the wire that they're fine. And we usually take that redundancy and put most of it intradural. But no, we haven't had any electrodes pull out or things like that.
Great.
Can I ask a question as well, Dr. Golfinos?
Sure.
That was incredible. Thanks for the presentation and the shout out also. But so I was curious, you were talking about in the pediatric group, it's really tricky to angle the placement of the device. Have you guys used endoscopes at all to try to assist that, or is it just too tight of a space in really young kids?
It's a tight space in the little kids. I mean, we've talked about it. We sort of haven't really done it yet. It's a really tight space. I mean, I can see where it will confirm that you're looking at what you think you are, but it's still, the hardest thing is not finding the foramen. The hardest thing is angling the electrode to get it in there.
Thanks.
Sure.
Carolina,
All right.
can I ask a question and make a comment?
Please.
Hey, Fred.
Do you have a case to share with us, or did you want
We
to?
do. I think Scott's going to do that because I
Scott,
actually have to go to a faculty meeting in a few minutes, and I can't be absent from that, obviously. John, it was a really nice presentation, and I'm really glad that you added the congenital inner ear malformation group to your presentation. You know, one question I had, why did you choose RetroSig and not RetroLab approach for the ABI in those kids, or even a partial translab, which might give you a more direct sort of approach, and as well more similar to what the cochlear implant approach would be?
Yeah, it's a great question. And last week we were sort of kicking ourselves for not doing that when I couldn't really open you know, retrosigmoid. The retrosigmoid door had too many venous channels in it. The problem is that the kids are so young, most of them, under 2 years of age, and hopefully around 18 months, that they don't have a really well aerated mastoid. So that drill out is a small space. And, you know, Tom Rowland does the drill out, and he's pretty quick at it and all, but we just haven't thought that there was, especially for a retro lab, it's still a small dural opening to try and slide that paddle through. So we sort of defaulted to retrosigmoid.
Yeah, no, I can understand that. And, you know, the other thing that you put up on one of your previous slides, you talked about, I forget the percentage, it was quite high, of auditory perception. And then a couple bullet points below that, you had 14% open set. And
Yeah.
I think that was in the NF2 group. I don't know if it's different for your inner ear malformation group. But I think that's an important concept to emphasize, and you did it well, in that, you know, these patients are really just getting access to environmental sounds for the most part. An occasional stellar performer, you know, will have real open set hearing, but you know, most of them just get, as you mentioned, you know, enhanced lip reading, for example, or ability to hear environmental sounds for safety. But when you have nothing, you know, something is better than nothing. And in the NF2 population, these are already mostly either older children or adults. And so they have a history of having auditory knowledge and auditory memory, whereas those very young kids, you know, the 18-month-old ones, you know, they don't have that, but they have the benefit of, you know, really being in that time period where, you know, their auditory central pathways are still malleable and potentially, you know, they can function once you have some stimulus.
Yeah, no, those are all great points, really. And yeah, I mean, and the funny thing is trying to predict who's going to be your great performer is a difficult thing. I mean, we sort of rely on, in NF2, we really rely on just implanting them as soon as possible. But other people have talked, other surgeons have said, oh, it's if you ever use any bipolar, then you're never going to have any good hearing results. I can tell you that's not true. So, you know, some of our best performers had bleeding during the operation. So, I mean, we try not to do, we do all those things, but it's almost like, you know, wearing your lucky suit for surgery that day.
Yeah, terrific. And my final comment would be that, you know, a lot of the NF2 patients actually can use a cochlear implant for a significant period of time, even those that have some really ugly looking tumors. And you'd think, wow, that nerve just must be so distorted, it can't possibly be conducting anything. But, you know, the case we're going to present, my fellow's going to present it because I have to run off to the faculty meeting, but that's a cochlear implant case. And, you know, would love to get your feedback on what you would think, you know, at the point, when would you say, you know, the performance of the cochlear implant is now so poor that we ought to take the tumor out and do an ABI?
Great. Thanks, Fred.
Scott, you want to share that case since we're sort of on that topic?
Yeah, I'd be happy to. All right. Share my screen here.
Are those palm trees behind you?
Yeah, no, I had to find a quiet place around here, but yes, I am outside of Miami. Not the worst place to do a fellowship.
No snow. Wow.
All right, let's see.
Not the worst place.
Oh, okay,
Is that a compliment?
Currently 81
New York, they
degrees
call that a
here.
New York compliment.
All right. Let's see.
Yeah, we can see it now, Scott.
Okay, great. All right. Let me get out of this. Go back.
Are you in presentation mode?
I don't think so. Can you all see things well here?
Yeah.
All right, great.
That's good.
So brief patient history. This is a 35-year-old male with an F2, obviously bilateral vestibular schwannomas, which you can see there on a T1 axial with contrast MRI. He underwent gamma knife treatment to the right tumor in 2010 and had no tumor growth over the last 5 years leading up to the initial assessment in 2015. The left had been untreated other than some Avastin in 2018. So from a hearing history, he had long-standing profound hearing loss on the right side, even prior to his gamma knife treatment. And on the left, he had some thresholds for hearing, but again, really poor to no speech discrimination. In his workup, he was found to be a candidate for right cochlear implantation, despite having no auditory responses with promontory stimulation. So we ended up doing a full insertion of a cochlear implant on that side, I believe in late 2017. And you can see the audiogram on the left side was his unaided thresholds versus his performance with thresholds in that right ear after cochlear implantation.
You gotta advance your slide. For some reason, the slide didn't advance to your audiogram.
Oh, you see a slide that says cochlear implant performance?
No.
No, we just see the initial MRI.
Shoot. All right, hold on one second. Here's what I'm going to try to do. I'm going to try to just share the portion of the screen that's relevant here. Next. Shoot. All right, well, let me just see if I can, even if it's in just the side screen, then I'll just do that. All right. All right, can you all see this?
Yeah, can you go to presentation mode?
Yeah, let me try. That's when it kind of got screwed up last time.
Gotcha.
How about now?
I mean, we see it. It's not in presentation mode, but it's fine.
Okay. You see the one that says cochlear implant performance, is that correct?
Yes.
Okay. Again, oh, here we go. I apologize if that's not coming in. Let me try this.
There you go.
All right, perfect. Sorry about that. So I included this MRI that he had after his cochlear implantation. I think this is a nice example of the artifact that you get from a patient like this without additional posterior fossa meningiomas or other tumors there. It's still a decent way of being able to monitor the vestibular schwannomas themselves. And so he had some additional treatment. Despite really not having much growth of that left vestibular schwannoma, he sought another opinion at an outside institution and underwent gamma knife to the left side as well in September of 2018. And then 5 months later developed left facial weakness. Was treated with 2 courses of high-dose oral steroids and ultimately had no improvement of his facial function. Has been at a House Brackman 4 since that time. And then after that as well, had that baseline 0% discrimination, but then his threshold sort of went to that profound level. So no longer really any perception at all. He had some internal necrosis of that left side without any real significant change of the right. And then after this MRI in May of this year, we decided that we were going to try a cochlear implant on the left, since he had pretty good, results with the one on the right, including some speech discrimination through that. And so we did the left cochlear implant in May, the rationale being that he had the worsened hearing and some benefit on the right side. Despite the artifact on MRI, we thought that the ability to monitor was pretty reasonable. And that kind of left us with the option to potentially resect, and if there was any residual or recurrent growth there, that we could ultimately resect that and do an ABI at that time. And so his performance on the left side has since declined and has not really met that for what he had on the right side, or at least hasn't met his expectations. Despite the equipment testing showing no malfunctioning, we have a CT scan that showed full insertion. And so kind of the question we wanted to pose was, when like Dr. Talisha mentioned, when do you pull the trigger and recommend a resection and an ABI for this gentleman?
So, and what's going on with the right ear again now?
The right ear, yeah, he's done fairly well with the cochlear implant on that side. He's had some increased thresholds and, is doing okay with some lip reading on that side, but he's not really getting much even in the way of open set on that right side.
Yeah, I think, we would probably have a pretty low threshold for this one. I think the interesting thing is, the whole use of Gamma Knife. And I got to say, I'm sort of a late comer to this, because early on we had patients who have been treated early in the Gamma Knife experience in the early 90s. Some of the first patients treated with Gamma Knife with NF2 who were treated with Gamma Knife, and they made their way to us for the ABI implants. And so we got to see them and follow them. And we had some patients who just had horrendous conversion of their tumors into these fast-growing things that were, at NYU, they're called atypical schwannomas. I don't know if they would have been called atypical in other places, but it was the pathologist trying to call them tumors that didn't look like regular old schwannomas anymore, even in NF2. So we were late comers to using Gamma Knife. Now, Doug Konzilka is here now in our faculty, and because we've seen the limits of Avastin, we're sort of not, we're not averse to trying the scheme of what you did, which is, Gamma Knife followed intentionally by a cochlear implant. And we'll tend to try and do the Gamma Knife before the cochlear implant, just so we can have a nice clean look when when we do the Gamma Knife MRI, so there's not an implant sitting there, although probably doesn't matter. I mean, as long as you account for some of the scatter from the processor, maybe to the overlying skin, but it probably doesn't matter that much. And you showed that you can really follow them nicely. But so I think, I would have a pretty short threshold to do, a pretty low threshold to do this. Also because we have a series of patients, and Tom Rowland would talk about this better than I can. We have a series of patients where we added the ABI to the CI, and it improved the CI the cochlear implant performance. So, and I think our fellow Nick Deep wrote that up, and it's probably on the call here somewhere. So yeah, I think combining the ABI with a cochlear implant will probably help the cochlear implant. That's what our experience has been.
Thank you. Yeah, I think we are kind of starting to lean that way. It's just a matter of patient preference, given that he's had that poor experience initially right after last year.
Yeah, the other thing that's important is, when you look at these scans and you say the patient has bilateral vestibular schwannomas, man, that is, especially someone who's had NF2 for more than 10 or 15 years, that's probably not true. They probably have bilateral vestibular schwannomas and the superior vestibular nerves, the inferior vestibular nerves, they probably have cochlear neuromas, and they certainly have facial neuromas, as we found out. Right? So, it's really a tumor on every single nerve. We just did this morning I said we did a lower cranial nerve schwannoma, but if you look at that little, she's 10 years old, and if you look at her MRI, she was diagnosed because her mother had NF2. If you look at her MRI, there are two little tiny dots of enhancement that are no more than 0.5 millimeter, one on each. One is in the inferior vestibular nerve on the right, and on the left it's in the superior vestibular nerve, and you can barely see them. But that's what's gonna, we know what's gonna come out of that.
Great. All right, Chris, you want to share your case with us?
Yeah, sure. We still have time?
Yeah.
Cool. All right. All right. You see the slides?
Yep, perfect.
Fantastic. Hi everyone. Thank you again for inviting me to participate here. I'm Chris Graffio. I'm one of the sevens here at Mayo Clinic in Rochester. I'm going to present a quick case on deafness that goes to 11 from the practice here. And the first thing I just wanted to say before I got started is that I'm really just, it's my privilege to present this case, but this is really the work of a tremendous team led by, Dr. Mike Link and Colin Driscoll. And this is a photo of us from, in the before times, back when we used to go to places and do things and have fun together. And hopefully we'll get to do that again someday. But this is, really the work of other surgeons that I, again, am privileged to present here. But so anyway, this is a 35-year-old woman who showed up with a 3-month history of ear fullness, hearing loss, and left-sided trigeminal sensory decrease, not total sensory loss. She had a congenital absence of a kidney, but otherwise was healthy, no family members known. She was adopted, but didn't have any other significant medical problems. She worked as a tennis instructor. She got an audiogram which showed bilateral class A hearing, marginally worse on the left, but 100% word recognition on both sides. I don't have the diagrams here. It was done at the outside. And of course, she got an MRI and they found paired tumors. And at this point, should I just go through what we did, or do we want to kind of talk through what Dr. Galfinos would recommend?
There's a couple of things here. The first question is, MSP, is that Minneapolis, St. Paul? Is that
yes, sir.
Okay, good.
Down the road a piece. It's like in Jersey.
Good. The second thing is, here's a woman who doesn't know what her past, her family history is, and she's 35 years old before she presents. So that tells you a lot. It tells you that she has a very mild mutation. So rather than a complete truncation of the NF2 protein, she probably has a mild one. And it tells you that she's going to have probably a long life, maybe not a normal life expectancy, but close. She's made it to 35 without even any hearing loss. And then you always want to see the whole MRI and make sure that this really is the classical NF2. Sometimes you'll see that it's the mutation that causes schwannomatosis instead, which is really a variation of NF2 more than anything else. The lucky thing is, it sounds like the left ear is the worst ear, and at least that's the bigger tumor. So she has that going for her. And then the amazing thing is, how is this woman a tennis instructor? How does she hit an overhead? How does someone like this hit an overhead by putting their head back? I'll never understand it, but it shows you the plasticity of the human brain.
Yeah, brains are wild.
John, she must play at the same level as you do, probably.
Thank you. Thank you very much for that.
Yeah, she's a tennis player in New York in the winter, maybe, not Miami in the 81-degree weather, which I assume is not Kelvin scale. So anyway, she was actually seen originally at an outside facility. They recommended resection via retrosigmoid craniotomy. They did a nice job in terms of the extent of resection. And at the end, from the outside surgeon's report, wave 5 was out somewhat, but still present. All the nerves were anatomically intact, but unfortunately, she woke with a House-Brackman 6 and class D hearing on that side. So essentially profoundly deaf.
Well, yeah, the other thing is we should talk about the whole decision to operate on somebody like this, right?
Yeah.
You don't have that many time points. She made it to 35. She still has excellent hearing bilaterally. This is all about hearing preservation. And we know that surgery is probably not the best way to preserve hearing, especially in a tumor that size. I mean, you may do it. Maybe you can do it 20% of the time, but that's a 1 out of 5 shot. I think the whole decision on when to go in is a complex one. And in NF2, we really probably would not have gone in right off the bat because she really didn't have basically.
Any other imaging, Chris? Did she have any serial imaging at all?
This is the immediate post-op picture. She didn't have any. They recommended surgery more or less right away. Get a diagnosis, debulk the brainstem. I haven't met her. I think that she, from kind of reading between the lines in the notes, I think that she wanted to have surgery to confirm what it was and, I don't know, reduce the risk.
You can confirm what it is with a blood test.
Yeah.
It's a little less invasive.
Yeah, not everyone, keeps up with the literature, I guess. But anyway, so after making her deaf and, partially paralyzing her face, she was, again, referred from Minneapolis down the block to Mayo for complex care. We initially saw her, and at this point, knowing that she's otherwise healthy, 35 years old, but has completely lost hearing with an intact nerve on the left side, would you intervene at that point from a hearing perspective?
Yeah, you might consider a cochlear implant in this case, right? The only problem here is why would we think that her cochlear nerve is intact?
Yeah.
If the facial nerve was supposed to be intact.
Right.
And that's not working. So
yeah, so
we would do a promontory stim on somebody like that.
Okay.
And see if you get and a lot of people don't do that. I guess they've always been doing it here at NYU, so they've gotten kind of good at it. So they would bring her in and do an outpatient promontory stimulation and see if she had any hearing precepts or percepts, and then refer for a cochlear implant.
Yeah, I can't tell you with certainty whether or not a promontory stim was done. I can tell you she went through the usual screening, metrics that we do here, and she was considered a very good candidate for a CI. She had pretty bad tinnitus, and there was and that was bothering her quite a bit. There was some thought that might improve, her symptoms. She really wanted it. It was approved, etc. And everything went very well in surgery. They got a good placement. Normal impedance, the nerve signals seemed to be normal and appropriate. But unfortunately, when they turned it on, she didn't get any significant sound perception. And she then started complaining that she was quite bothered by scalp tightness and by headache. And, the device was really irritating her. And she asked to have it taken out, actually. And I'm curious if that's something that you've come across often, that people either feel like they're not getting benefit or they're getting, their other headaches or their tinnitus are worsened by the device.
No, I don't think that happens very often. If it doesn't work, most of the time it doesn't cause that many adverse effects, so it usually gets left in there. I think what happened here is you had a patient whose life was perfectly fine. And now, a year later, she's sort of realizing that life is not going to be fine anymore.
Yeah.
So I think I think that's part of what's going on here.
Yeah, it's an unfortunate story in that sense.
Yeah.
And it doesn't get better. So they took the CI out, and the tinnitus persisted, and she just went to routine surveillance at that point. And over approximately 2 years, she started showing a little bit of serial growth on the left side. The right was completely stable. And what, from a tumor control perspective, would you discuss at this point?
If you're really concerned about that left side that is progressing, then I would, it looks like it's really growing. How's her face? It's still a 4?
Face got back to about a 3.
So like a generous 3.
Yeah.
Yeah. I guess I don't know. I still shy away from radiation. If you show us to Doug Conzioka, he'd radiate that left side in a heartbeat.
Sure.
I don't know. I'm still a little gun shy in patients with NF2, especially one as young as she is at 35. So I don't know. I think Translab is perfectly reasonable. And the question you want to ask is, would you put a sleeper implant on that left side? So a sleeper ABI, which she won't use until the day she loses the hearing on the right side. I think that's going to be a hard sell for this patient.
So I'm really curious why a sleeper rather than an active device.
She won't use it. She has normal hearing in the right ear. It'll actually decrease her hearing performance on the right side.
Interesting. So what ended up happening is, so she was Avastin was discussed. She wanted nothing to do with that. Gamma knife was discussed. She wanted nothing to do with it. Those were not I recommend is probably even too strong of a word, but they were presented as possible options, as was a Translab, and to finish the resection, and to put an ABI in, and the operation went very well. They were able to get all the rest of the tumor out. They actually did find intact nerves, 7 and 8. And they were able to get the ABI in with a good evoked response.
Yeah, looks great.
Yeah, perfect paddle position, honestly. And they did all the stimulation tests that you discussed in your presentation earlier. That make sure it wasn't stimulating the vagus nerve or anything else, and it all looked excellent. Woke up again with a stable House-Brackman 3, and then afterwards, again they decided to turn the device on, and she wanted this, is my understanding at least. And it had.
You do turn it on, but you turn it on for sort of training, for the day when they won't have hearing on the right. Is the idea.
Okay. Interesting.
But they tend not to use it for many hours during the day.
Yeah. So as she started using it over the course of a few months, she started getting a bunch of other strange symptoms, and nothing that referred to other cranial nerves. So no weakness or dysesthesias, just generalized like malaise. And she said that she would hear noises, not her tinnitus, but a new kind of just disturbing sound in that ear. And she was pretty bothered by it.
When the ABI was on or off or all the time?
When it was on.
Okay.
And so again, she wanted it out. And pretty soon, after just a few months, would you have counseled them to keep it in for a while longer, to just turn it off and ignore it?
Yeah, I would have turned it off and ignored it. I think, this is a tough case. And this is really a person who we have let down as physicians multiple times. We try and present realistic outcomes to patients ahead of time. The best doctor is one who sort of predicts the future for the patient. So they come back and say, oh, it's exactly what you said it would be. We've kind of let this patient down a couple of times. So, wow, I got to tell you, I've never pulled out an ABI. How'd that go?
So they didn't pull, though. There's, I think Dr. Link was telling me the other day, there's 2 of them that I know of that were taken out. One of them got a bad abscess and they took the whole thing out and it went well, mercifully. This one, they cut it at the paddle. So they left the paddle in, but took the rest of the hardware out. And it went very well. She woke up fine. There were no issues with the procedure. But unfortunately, she's now got the right-sided tumor, of course, has started to progress a little bit. And over about 2 years, she's got another 10 decibels or so of hearing loss on the right side. And this is sort of where we are now. So, we're going to see her back probably in another month or 2. This imaging's almost a year old, and we've been observing for the time being. But my guess is she's going to have further progressive growth on the right side. So what do you think sort of the next steps would be here for this?
I think an only hearing ear, this is a perfect Avastin candidate. And then she needs to start, getting involved with the clinical trials in NF2 for whatever comes after Avastin, which right now doesn't look like a lot right now. But, this is a perfect Avastin case. And I wouldn't, for 10 dB hearing, I don't know. If it's growing, yeah. She's a perfect candidate. She fits all the.
Hey, Chris, did the funny feelings go away when they cut the ABI?
Supposedly, yes, or at least they became less problematic. She wants more surgery, which we've told her is not a great idea because she's probably going to lose hearing on the other side, and then she's going to be very unhappy, and that would be a disabling thing to do. So the current plan is basically observe for the time being, strongly consider Avastin. And we've got her set up to see nephrology as well, because I know that one of her big concerns with Avastin is, given only one kidney, if she were to have a complication, would that send her down a really unfavorable sort of medical complication pathway? So it's not an easy decision, unfortunately. And Gamma Knife, I think, is on the table, but she's reluctant to do the radiation thing. So we'll see.
Yeah, no, I think she's a good Avastin candidate. I think, the other thing that has to be done in all these patients, they need to be sent for American Sign Language training, for lip reading training, and just, it may not happen. Hopefully it will never will. They may never need it, but, they really need to be set up for that and learn all that and understand that someday she may lose that hearing in the right ear.
Yeah.
More likely than not. Yeah. And also obviously genetic counseling, all those things.
Yeah, absolutely.
That's
all I've got. Thank you again for inviting me to participate. This was fantastic.
Thank you. I think Dr. Link's going to wait till you graduate for that re-op.
I think he's going to wait till I graduate and then refer it.
So, Mike, you want to pull up your case? Just a related question from the audience. How does one differentiate between natural tinnitus and tinnitus from implant malfunction?
Wow. On a cochlear implant? I can't speak that well about cochlear implants. It's not usually referred to as tinnitus when it's an implant malfunction. It's usually an off auditory precept, and usually you can tell by turning it on and off if it's coming from the implant. But tinnitus is, most of the time just coming from the loss of hearing. So it's it's directly related to the loss of hearing, basically.
And then one more quick question is, what's the maintenance, if any, that patients have to routinely go through once they have an ABI implanted?
So the more training they do with the ABI, the better, and the more mapping that they do, especially early on in the first year. So they'll keep remapping the electrodes to see how they can give them more pitches. The more pitches they have, the more pitches they can discriminate, then the better their speech perception. So they'll do that all through the first couple of years and even after that, because the brain is plastic, things change. So it's kind of a lifelong relationship.
All right, Mike.
Yeah, can you hear me?
Yeah.
Oh, okay, great. Dr. Golfinas, thank you so much for agreeing to give a great talk tonight. That was phenomenal. I feel like we should have had it here before we perhaps called you down to do the first ABI, but thanks so much again for all of your support and really kind of helping our program get started. Sure. This is a much more simple kind of questions case. This is one of our cases that we did down here is a young female with no NF2, with kind of a slow change in hearing on the right. Left hearing was completely out. Already had an ependymolar resection 6 years ago, but otherwise was intact, and kind of was lost to follow-up for many years, and now shows up with some mild headaches, and obviously, you know, it has multiple tumors. And I think this case kind of highlights that all those decisions that kind of go around ABI and bilateral acoustics and how to manage that. I mean, I think in this case, there's no question what needs to happen first, and that's resection of the meningioma, which is what we did. And you know, so now this is what you're kind of left with is the left frontal meningioma is resected. She has this posterior kind of falcine one that's very, very slowly growing, 1 millimeter a year. The acoustics also very minimal change on like a 1-year follow-up, but slowly, but no hearing on the left, and starting to slowly lose hearing on the right. And the ependymoma, which is just a dot here in the medulla, has been stable for 6 years. So the question is, you know, when do you kind of alluded to in your talk, you know, earlier transition to ABI, you know, when somebody loses hearing is they do better. But, you know, talking about Avastin in this case as a possibility to try to preserve hearing, you have another tumor that's growing, but it's small, asymptomatic. How do you can you just talk through kind of how you manage the complex care of some of these NF2 patients with multiple?
Yeah, absolutely. Yeah, this is great because it's sort of the typical NF2 case. So, you know, it all comes down to the type of mutation that they have, or the severity of their mutation, really. And it's interesting that some patients generate more meningiomas than patients who generate more problems with schwannomas. So, you know, every patient kind of is different because they each have a unique mutation in that NF2 gene. So usually for a patient like this, I mean, you know, she's going to look at surgery a couple of times probably in the future. So I tend to be pretty conservative about it. I mean, I sort of only operate on the tumors that really cry out for attention, like you did for the frontal one. The good news is she has no hearing on the bad news is she has no hearing on the left. She has an only hearing ear on the right. I think, you know, the whole goal for her is just to preserve that hearing on the right for as long as you possibly can. So I don't, you know, unless that left tumor explodes and you have an opportunity to put an ABI in when you take it out, which would again be a sleeper ABI, since she has good hearing on the right, or better hearing on the right. I don't think you're going to touch that left side tumor. The other thing is when you look at that MRI, you can see that there's tumor already in the cochlea, it looks like, or else in the facial nerve on the left. Certainly in the facial nerve on the right, it looks like it's going out either that's in the cochlear epididymis or going out the labyrinthine segment of the facial nerve. You know, this is what you see in these patients. It's not just one little tumor in the IAC. So I tend to be really conservative with these patients in terms of pulling the trigger for surgery, and then when surgery comes, trying to be as aggressive as possible.
Yeah, and I think there's actually, I'm not sure if Chris, if this is out of the Mayo Clinic, this idea of meningiomas in these NF2 patients, a very small amount of them actually grow at a fast rate, and most of them kind of grow at a very, very slow rate, 1 to 2 millimeters a year. And so the idea
remember that in NF2, right, all these meningiomas are NF2 driven, and in NF2, over half of them will be atypical, right? Especially if you do next generation sequencing, you'll find multiple hits. So, and the hardest thing is that one you see there with the sagittal sinus. This is all about the veins in these patients. This is all about trying to preserve both cranial volume as long as you can. You already have a cranioplasty in the left frontal, and you want to make sure that you preserve the cranial volume when you do that instead of putting in flat meshes and things like that. And then also preserving as many veins as you can, because those are precious in NF2, as you can see in that sagittal image on the left there.
Yeah. So eventually we tried to enroll her in Avastin, but because she, you know, poor insurance, unable to get it. So we followed it for a year, and very quickly over the year, kind of the word recognition score basically went down to almost 0 on the right and was already gone on the left. And so then the question is which side do you operate on? we felt like there was just slightly amount of hearing on the right, so we decided to go for the left. Both of them were not growing, so we ended up doing kind of an ABI in the left. And then the question is can you still see the other tumors like we talked about? And obviously there's many good kind of pictures showing that you can. This is just what our post trans lab here on this side. So she did really well with this one, and obviously this is what you can see. You can still see that meningioma really well. MRI shows the artifact is there. But the post-op care, I wanted to ask you about, out of, I think we've done 4 so far between Dr. Morkos and myself here. And I think out of those, 2 of them have both kind of developed large pseudomeningal seals, hydrocephalus, and whatnot. So obviously it's very hard to get a watertight closure in these cases. We placed a shunt in one of them, the other one we managed conservatively. What are your kind of experience with the post-care management of the pseudomeningal seal in these patients?
Yeah, no, I love this question. We just had a little baby that we did. He wasn't even that young. How old is he? 2. And we just did him 3 weeks ago, and he came back with a big old pseudomeningal seal. And I'm convinced that it's sort of the amount of bleeding you get into that in this location that determines, how bad your postoperative aseptic meningitis will be. So, and they never come in until you start tapering the steroids, and that's when they get the pseudomeningal seal. So I don't have a great answer for it, except I think, I love slow tapers, almost like an epidermoid taper for steroids, keeping them on the steroids as long as you can. Trying to get as little blood as possible, I think, is a big deal, especially when you put in the ABI. You can get in there without any veins bleeding or anything else bleeding, then those are the patients where I think we haven't seen big pseudomeningal. So we actually asked our fellow to look at exactly that question, because she just started in July, and she saw her first pseudomeningal seal. So we're going to try and figure out if we can predict who's going to get one and not.
Yeah, I mean, it's always an anxious thing because it typically, at least in our cases, it was big enough that I was preventing the use of the ABI because the fluid collected in there. So now you have this patient that went through this big surgery, is already, and we're trying to do the programming and whatnot, and they want to start using it, but yet you're limited by that. So do you pull the trigger on early shunt, or do you try to watch it and wait it for a couple of weeks?
We bring them in. We bring them in, and everybody gets a lumbar drain, which in the little kids, you can imagine, is not. They have to basically get heavily sedated or go under anesthesia for that. So we bring them in. We get a CAT scan, make sure there's nothing, or in the kids, like a fast T2, just to make sure there's nothing really weird going on, and then everyone gets a lumbar drain, and that kind of works. It's the old treatment for aseptic meningitis. Was basically lumbar drain or multiple spinal taps. My predecessor, Pat Kelly, used to say, you can pull the drain when the spinal fluid looks like the color of Jameson's Irish whiskey. I have no idea what color that is, but I guess it's like a very light yellow. So that's what we manage it. And do you use Tissio on these cases to hold the ABI in or anything?
We have in one case. The other case, we kind of just wrap, the fat, you kind of suture around. I'm not sure, Dr. Morkos, most recently, have you done anything different?
No, I just did one yesterday. I'm going to do another one Monday, John. No, I don't, no, I just stuffed the fat there. And as you suggested when you came to visit us last year, just, leave enough room for forward memory of the wire.
Yeah. And you purse string the dura around the wire and hope that that's enough. And
right,
I don't have a really good answer for it. I wonder if sometimes I put the Tissio intradural, and I wonder if that has anything to do with it, because it's kind of another.
I don't use much TCL anymore. I don't really think it does anything, but.
We use it in essentially every case for at least Dr. Link's practice, and I don't think there's a significant incidence of aseptic meningitis with it.
Good. No, I'm so happy to hear that. Good. What do you do for your aseptic meningitis at Mayo, Chris?
What aseptic meningitis at Mayo? We don't have that here.
You think the cold weather prevents it?
Probably, yeah.
Everybody's wearing those tight hats around there. Because it's so cold outside. They don't have it.
Right.
Yeah, steroids. I mean, I haven't seen the lumbar drain thing. That's a slick idea, but
it saved us in the kids. Yeah, lumbar drain in the kids is great. I mean, the pediatric ICU hates it, but it has saved us multiple times.
Yeah, that's great.
Fantastic. Well, thank you, everybody. We really enjoyed the talk and all the case presentations. Dr. Golfino, it's always wonderful to see you. And stay warm.
Yeah, thanks, boss. It's like a hobby of mine is doing webinars with you. I love it. It's good to see you again.
Great. And don't forget the North American Skull-Base meeting, virtual symposium in February, and then a real meeting in 2022, one hopes.
All right.
Hurrah.
Bye.
Perfect. We'll be there.
Good night, everyone. Thank
Good
you.
night.
Take care.
Night.